So this one's going to be a short class, and this is a short topic. And as JRs, you must pick up if you ever get bladder imaging cases, just pick them up for reporting. So this is all about practice. The more you see bladder MRs, the more confident you will become. Okay. So let's go. So what we will mainly be discussing is VIRADS and how we score bladder tumors. Just for some sort of context, I'll tell you how important these cancers are. Okay. So, overall, bladder cancer has a grim prognosis, a poor prognosis, because whether it is muscle invasive or not muscle invasive, the prognosis doesn't, it doesn't become favorable. As you can see, there is high recurrence rate. I hope you remember what is field cancerization. Do you know what is field cancerization? Can somebody tell me what is that? And why is it seen in bladder carcinoma? So whenever you have a risk factor, right, and you have high chance of synchronous cancers in that organ, that is what is called as field cancerization, and that's something you see in bladder, you see in the oral cavity, where even if you pick up one lesion, there is very high likelihood that there can be other synchronous lesions or metachronous lesions which may then occur. So bladder is one such organ where in a lot of patients you'll see more than one lesion. Okay, so that is something which is important. And just at the outset only, I'll tell you, when you are giving the VIRAT score, you give the most severe VIRAT score. Okay, so whatever is the largest lesion, that is what you will pick up and give the VIRATs for in case there are multiple lesions. So field cancerization is a concept that there is a exposure of a carcinogen to the entire organ. So if I have one bladder cancer, that patient overall becomes a higher risk candidate for developing other cancers in the bladder. So that is a concept that is there in three cancers: bladder cancer, oral cavity cancers, where you can have multiple subsites getting involved, and then melanoma, which is not very relevant for us in India, but overall, field cancerization concept is used in these three organs. Okay, so that's why it's a poorer prognosis, because multifocal cancers are commoner. Yes. So now why? So basically, what you have to understand, for those of you who are just getting exposed to bladder cancer staging for the first time, as radiologists, we have one singular role. That is to say whether it is muscle invasive or not muscle invasive. And that is what, the clinician wants to know. They already know there is a mass, they will biopsy it, and they will know the histology. So histological diagnosis is not what anybody is looking for. They want only one thing from us, and that is whether it is muscle invasive or non-muscle invasive. So I was saying that whether it's muscle invasive or non-muscle invasive, it's not really a very good thing for the patient, because see this: 80% of those which have a relatively less severe cancer, non-muscle invasive cancer, also relapse within 5 years, and 30% progress to muscle invasive despite surveillance, right? So that's why it is a bad prognosis for the patient. This is just for you to write a good theory answer. Smoking is a biggest, most common risk factor for CA bladder. It affects men in fifth and sixth decades more commonly. Exposure to chemical carcinogens like aniline dyes, right? That's one risk factor. Radiotherapy to pelvis. So this is one thing which, if a female has gotten radiation for CA cervix, she becomes higher risk for developing bladder cancer. Chronic cystitis. Important, 90% are urothelial. I think you guys know this, right? That we have a transitional epithelium, and TCCs represent. So I'll just repeat quickly for, so that we can just get reoriented. CA urinary bladder, our main job as a radiologist is to decide whether it's muscle invasive or non-invasive. These are the risk factors. So whenever there is, chronic inflammation, you have to suspect squamous cell carcinoma. 90% of the cancers are TCC. So that's the norm for, smoking, for aniline dyes, for radiation, we'll have TCC higher risk. But for chronic cystitis and calculi, whenever you have a background of chronic inflammation of bladder, we want to suspect squamous cell carcinoma, right? So that's something which doesn't really change the prognosis, staging, nothing, but just a suspicion. And you know that adenocarcinomas are associated with urachal remnants. That's something which is also a very important spotter, that they can show you a CT scan with a urachal remnant, and then there is a mass. You should always suspect an adenocarcinoma, right? So that is about an introduction. Now we get down to the main stuff that is important for you all to understand, okay? And this is very, very conceptual. If you understand the next three slides, you will never have to read bladder VIRADS again, okay? Repeat what part? This is just introduction, right? There's nothing much. I'm just starting now with the most important part, okay? So there's nothing really to be repeated in what I've already covered before, I had a power cut. So I'll just focus now. Okay, so basically the TNM staging is here, but what we really need to remember is two types. So we have non-muscle invasive bladder cancer and we have muscle invasive bladder cancer. So now look at TNM and we corroborate the two things. So TA is non-invasive papillary carcinoma. So this is where you have a papillary growth without any sort of invasion into the wall of the bladder. TIS is carcinoma in situ and T1 is where it involves the lamina propria. So non-muscle invasive includes three T stages. What all? TA जो कि papillary है, TIS जो कि carcinoma in situ है, and T1 which is only going till the first layer, that is lamina propria. Okay, so these are mostly papillary lesions. They are often multifocal with low malignant potential. Can somebody tell me how do we manage non-muscle invasive bladder cancer so that you understand the relevance of why this classification is important and why VIRADS came into being? Not just intravesical BCG, right? You first want to remove it. So how do we remove it? So you first want to do TURBT. What is TURBT? It is transurethral resection of bladder tumor. So basically you are doing a cystoscopic or a transurethral resection of the tumor first, and then you can give intravesical BCG or any sort of contact chemotherapy like mitomycin, right? So all of this is intravesical and not systemic chemotherapy. Okay, so this is for non-muscle invasive. Anything else? So see T2 where it's invading muscle, T3 where it's invading perivesical tissue, and T4 where it's going into adjacent organs comes under muscle invasive bladder cancer. Strongly associated with metastasis. How do we manage muscle invasive bladder cancer? So there we have to remove the complete bladder, correct? So there the management is radical cystectomy, and sometimes, so this is for only T3. Only for T2. The moment you have T3 and T4 means it goes outside the bladder, the patient will also be offered neoadjuvant chemotherapy, right? So basically radical cystectomy plus minus NSCT for muscle invasive as a group. So because the management is radically different, that is why this classification is very important for us to know as radiologists, that what is the implication of calling it muscle invasive or non-invasive. All right, so that is what is the background here. Let's just look at the lymph nodal staging. So you have single lymph node in the true pelvis, that's N1, multiple regional pelvic lymph nodes N2, and common iliac tak chala gaya to N3. So pelvic lymph nodes perivesical, obturator, internal or external, iliac, and presacral, right? So this is for the nodal staging. Right. So let's further add on to this. So this is what is your very, very important slide, that multi-parametric MRI is the main workhorse on which we are going to do VIRADS. Okay. So VIRADS is not given on any other modality except multi-parametric MRI. And this is very similar to multi-parametric MRI that we do for PIRAD scoring. Okay. So more or less the protocol is the same for both. Okay. So let's understand this. Okay. So you have these layers. So you can see this is the urothelium, which is the transitional epithelium, and lamina propria. This on MRI is going to look to us like one layer. Inner layer bolenge isko. Then we have the main muscularis propria, where we want to see whether the tumor is superficial to it or invading into it, right? So this is our second layer, which is muscularis layer, and then you have adventitia or serosa. Okay, so these are the three layers that we see. So on MRI, what are the three layers? Urothelium and lamina propria together make the inner layer. Detrusal muscle and perivesical fat. Okay. So now let's understand this. Okay. So see this image. Can you all appreciate here that let's assume this is the cancer. Okay. So this is the cancer that has been shown here. Now can you see 1, 2, and 3 layers? Right. So this is the inner layer, which is your lamina propria layer, okay, and the mucosa. What is this? Is the muscle layer, and this is your perivesical fat. Essentially, this middle layer is what we are interested in, isn't it? Whether the cancer is superficial to it or is it going here? Yeah. So now let's understand. Is T1 weighted really useful in bladder cancer imaging? It's not. Why? Because even cancer is intermediate signal